Thank you, and thank you to the organizers for having me here, even though it did mean I had to write a completely new talk. You can't go to any meeting without hearing about artificial intelligence and machine learning, so I'm going to talk about how that plays into radiation protection and dose optimization. These are my disclosures in terms of research support and other roles that I fulfill. I need to move over to see these. So artificial intelligence is a nested concept, and it's essentially intelligence being shown by a machine. And I always like to note the machines were created with human intelligence. The machine learning algorithms take data and train a task. And these tasks aren't something that you know a priority what the equation is to get from A to B. You let the machine learning tools get that answer for you. And then the deepest level is called deep learning, and that uses what they call artificial neural networks that are actually patterned off the way our brain works and the synapses. So another way to explain it is that machine learning is most helpful when you have lots of data. You know the input, you know the output, so you know the answer. You don't know how to write down the mathematical equation to get you from A to B. So unlike classical type programming where you have an equation, here you are letting the data guide the system into that transformation. So the good news is you don't have to come up with the complex rules, but the bad news is you don't have rules to know if mechanistically the system is doing the right thing. So how the training works is you start with your input examples, you have output examples, and you start with a neural network that is totally, you could have 0 for all your weighting factors, and so you get totally useless output. But you compare your first guess against what you know the truth is, and you have some sort of function that weights how different they are, and you decide then how you want to go about optimizing to make that parameters now tunable so that you keep adjusting and adjusting till you've optimized it. Once you do that, you lock in your parameters, and then you can put in new examples, and you expect to get the useful output that behaves the same way as the training data. Now, an artificial network looks very complex, but each single element is fairly simple. It uses very simple linear mathematics in a node, and you have the data, you have different weighting scales or weights, and you get some output. That is a node, but to do a complex task, you end up getting many, many nodes with many weightings, and so these can be in the millions. So we all know that our Facebook or our phones can recognize photos of people, and so machine learning and deep learning has been in the commercial sector for quite a while, getting better and better. And so we need to recognize this person. It's my sister Sarah, and I want to find all the photos of Sarah. So I train with data, and each of these pathways starts to look for different features. So at first it's kind of dark lines, big picture features, and then more and more subtle features until finally it learns the weighting for Sarah. And so then you can take this weighting, and it has extracted the features, so any other picture of Sarah at the beach or the Christmas, we'll find her. That is the idea. So AI has been used in many different areas in medical imaging as well, and these are some of them. I'm not going to talk about the ways we use it once we have the data, such as the segmentation for doing radiation therapy treatment planning, or in fact, are optimizing the treatment plan itself. I'm going to talk about how it affects the dose to the patient. So here's a diagram of the CT exam workflow. And so actually AI can be used at every step in this pathway. So first thing, put the patient on the table, and you have to center the patient. So the system does something called automatic exposure control to figure out how attenuating the patient is, so how much dose it needs to put on the entrance side to get the right detector dose to have the right image quality. the system relies on some geometric measurements. And so in the middle panel there, the patient is at the center where they're supposed to be, and the geometric measurements have been calibrated assuming the patient is at center. But if the technologist puts them too high in the gantry field or too low, you will get a different answer, and the system will think the patient is either less attenuating or more attenuating, and that will impact both your dose and your image quality. So patient centering is actually very, very important, and I don't think a lot of radiographers understand just how important it can be. It's for automatic exposure controls. Again, they assume the patient is centered, and they're not always centered. And so what the system does with this measure of attenuation is it modulates the tube current to modulate the number of photons so that there are more going through dense projections through the shoulders, and then there are less as you get into the lungs. And so it needs to know what the patient's attenuation and body habitus is, and that is the key to why you need to get the centering right. So there is a camera that we have just installed. It's a commercial product now that is a 3D depth infrared sensor. The arrow points to it there. It's above the patient table, and it uses the light to measure the distance to the object and get a three-dimensional profile of the patient. And then it makes this virtual avatar based on the data that it has and a sense of what a human body should look like. Then it takes and looks for landmarks, and it can even find landmarks under blankets because it has been taught what those things look like. It also knows what a patient laying head first or feet first looks like, so that if the technologist has put that in incorrectly, this can fix that. So it has been taught these things. It has a deformable mesh of humans, and the training was done in over 1,000 patients from 3 different hospitals. And so it's kind of fun. Everyone that comes in the lab, we say, hey, lay down on this, and we'll see where it centers you, and it's very robust. And then it does this step automatically. And this was a study done that you can see 2 different body regions, chest and abdomen, and the manual centering, as the technologist did, can have errors of 20 millimeters, 2 centimeters, with a maximum error up to, say, 4 centimeters. And the last column is the percentage of patients with more than a 2 centimeter error. And manually, that's 50% in the chest and 40% in the abdomen. And you can see there were no errors that large when we used the automated camera. So that is one application of AI that is already in practice. And then we have to take what we call the localizer radiograph to basically do a chest x-ray or abdomen x-ray to decide where you want to put the scanned irradiation. So you take something like this, and the technologist usually then has to draw the lines for the start and the stop of the scan, and they might do something like this. Well, we know that unnecessary dose is given to patients if the technologist is a little too generous in drawing that. And you have inconsistency because different technologists have different thresholds. And so here, if the scanner is told this is a chest exam of the thorax, AI can recognize lungs. That is a very straightforward thing to train it to do. It can recognize the cardiac shadow, and so the system can automatically put the boundaries over where to scan. Now we go to protocol selection, and this we still need the human for. The referring physician, the radiologist need to look at what the suspicion is, and are they doing the right exam for that? Kidney stones, lower dose, appendicitis, could be MR, could be CT, so there's still thought process there, but even that is changing. And then we go to the scanning technique, which of course is the application of the radiation, so very integral and important step, a critical step in this process. And I'm going to start on the dye, the contrast media iodine that is given in CT to help accentuate soft tissue and blood vessels. It is injected according to a protocol that is traditionally been, until AI, very generic. And so there are some different points in time. Go, we hit the button, we hit the inject button, we start the scanner going, And then the dye starts to be measured in a region of interest you've placed inside your baseline image of the patient. And then you get to the point that is above a threshold. And so now you are bright enough to take a good exam, and they know that there's still a bit of buildup of the dye, and so the scanner has a fixed delay set by the institution of the radiologist. And in this case, the orange is a yellow scan duration, but for this profile, the dose of iodine is still going up after the scan is over. So we've given unnecessary dye, or we've gotten not as good images as we'd like. And in fact, if we put it really in the wrong place, we can be where the dye is falling off and we get a poor exam, and then we have to repeat. So again, using AI, we have now a system that individualizes this time to the scan, the start of the scan. So this is an example where that patient's circulation was much delayed, and the peak happened much farther out in time, 30 plus seconds. And so if we had scanned with the fixed delay, we would have not given that patient the best scan. And once you know the peak, the system sets a window around it, and that's where you scan. Now, it did this with AI. Lots and lots of patient input data, and the input data is manual tracking of the dye that is also done in many clinical exams. And what they looked at is just the very input, the tiny foot of the curve at the start of injection. And the truth that they knew was what ended up if they tracked the whole duration of the dye in and the dye out. And what they found was that they could train from those initial 2 or 3 points where the dye is just rising, that they could train the algorithm as to which curve that patient would fall on. And so you get then, if you've individualized it, better uniformity of dose, or excuse me, of the contrast enhancement, but that is a dose, it's an iodine dose, and it then avoids repeated scans because you've missed the bolus. So we did a study on this, and on the left are the individualized delays. This patient happened to have started relatively late at 18 seconds. On the right is the fixed delay, and we scanned patients that had had a prior exam with the fixed delay. They came back, we did the individualized delay. And as the study went on, we realized we didn't need as much dye as we've been using for decades. So we actually turned down the mass of dye, the volume of dye given, and we also turned down the rate. Both of those things are safer, lower rate, you're not as likely to burst a vein. And then we did some quantitative analysis, but I'll just point out these two vessels there at the base of the pelvis, and they're pretty bright. Well, they're bright over here. It's a diagnostic exam, but you notice they're not as bright. They are really full of dye on the left, and sometimes the amount of dye can make or break an exam. Now, the other thing that people think about with dose is not typically the iodine dose, but the radiation dose. And so the tube potential, the tube current, those are the primary settings we think of. But the scanning technique for AI dose reduction is coupled with the post-processing or the reconstruction. There are research groups taking from the raw data and reconstructing right to a final image that has a lot of challenges to it. So I'm going to talk about image denoising, which is much more trustworthy. Very smart colleague, excellent group. They did an automated reconstruction, trained in on all these abdomen exams, looked beautiful. He said, scan my backpack. What does it do when it gets something it was not trained on? And the backpack looks like an abdomen. So what do you do if you have a patient with anatomy that was not in your training set for some reason? So this is work from one of my postdocs, Andrew Mizzard, and we know truth in the sense of we know a good quality image and we know the low dose noisy version because we have a simulation tool that's very physically accurate. And so we have a whole bunch of low dose images that we've simulated, done the exact same reconstruction. We know the real dose images the patient got, and we trained an algorithm to identify noise, not the anatomy, but the noise. And so this is an example of the simulated 25% dose, pretty nasty-looking images, especially the one on the right. And this is the denoised. And the first thing that the brain perceives is it's blurry. Because when you remove the high-frequency noise, your brain is used to that having been blurred. But let's see if I can get the back arrow. Pick an edge of a ridge, the rib, the edge of the liver, and watch it as I go back and forth. There's been no impact on the spatial resolution, but we have trained it to know what noise looks like and then to subtract it. And we did this on this low dose, but we found that if you then took a regular dose image and made it really sharp, so it had better resolution, it also worked there. And so we are getting some very, very nice, sharp images in the abdomen that people would not usually have gotten because they wouldn't want to go to the extra dose to keep the noise down. But in this case, we use the denoising. Now, blurring is bad. Any denoising, yes, that is a real word, or other noise reduction that you do, if it alters your spatial resolution, it has not accomplished the task of just removing the noise. And so we always evaluate the spatial resolution. So those purple lines there are profiles through the smooth, low noise image that you would use to smooth out an image if it was too noisy. The sharp image gives the very peak profile. The smooth one is kind of the low, squatty profile. And what you find is with our CNN, the sharpness is identical to the sharp reconstruction. So we do these kind of tests to make sure we have not lost resolution. So if you have noise reduction at the end of the chain and you know it works well and you know it doesn't in any way damage the image, then you can go to the front of the chain and turn the dose down. And this is from our own practice. I've been there long enough to know where all the records are. And this is what body CT doses have done in the last almost 4 decades. And the ICRP report that actually just hit the press yesterday also shows how doses continue to fall because of the new technology and the better awareness. But, while the doses are falling, the images have gotten better. So it's been an extra benefit because thinner images are noisier. And so not only have we dropped the dose, but we would have made the images noisier if we had not had better technology. But there is a limit to this diagram. This is not linear, non-threshold. There is a threshold. There is a point below which it is harmful because the physician may miss the correct diagnosis. There's no benefit. And some radiation, whether it's low or not, is immaterial because the physician needs the information to care for the patient. So, CT is fundamentally about photons. Photons behave in a statistical fashion. And you can do all the denoising or artificial intelligence you want, but if the information content, the signal, is simply not there because of too few photons, you will not be able to recover the information. That's why we can't drive the dose lower and lower and lower, because we will get to a point where there is no information. Now, those in image science who know the Rose model, you know exactly what this picture is, so not fair if you answer. But from this, are people confident that they know what that is a picture of? No, the information is not contained. Now, if I start to go up in dose, more photons, I get past these statistical limitations, and there, because I know what the image is, it's obvious to my eye. Still might be challenging for some people, but with more and more photons, the picture appears. Now, this is still not a great picture, but if I just need to know that's Sarah or that's a woman, that image quality is fantastic. But I need more photons if my task gets harder and harder. Here, her complexion is still modeled. But here, if I had to, for some reason, know about her complexion, I'm a dermatologist, I'd need this level of photons. So statistically, there is a limit. And here's even better. Now, that has not been well realized in clinical practice, unfortunately, because the new technology comes and everyone gets excited about iterative reconstruction, and we can just keep dropping and dropping the dose. And this is from a clinical scan at one of our satellite practices. The manufacturer very nicely drops the dose for you when you turn on iterative reconstruction, and it drops it by 72%. And so we would argue the information's essentially almost gone, but the images look pleasing to the eye, and the radiologists have not complained because they perceive them to be a good quality image. We did some different evaluations and observer detection type models, and we realized that was just not possible, not from anything else we'd seen. And so we talked the radiologist into increasing the dose, and then the lesion is very obvious. Now you have enough statistics for the iterative reconstruction to not wash out that value. And now that you know the lesion's there, you go back, it's in every other exam, but the dose was too low. And so I always give this caution in our quest for low dose. We have to be very careful because a radiologist will not know they've missed something if they can't see it by definition. Also about artificial intelligence, it's well known in the field that is not fully generalizable. So those images I showed you that were so nice, we trained them on images of that same reconstruction kernel. Here, up, down are different reconstruction kernels, and it may be hard to see in this light, but the performance is not the same because we trained on D30, and the D20 and D40 do not behave as well and actually lose resolution, which was one of the things we wanted to avoid. So, in summary, AI is new technology that's been improving for years, but it's like any new technology, right? It comes out first and everyone thinks it's awesome, it's gonna solve all our problems, the future is solved, and then we work with it for a while and we're like, it causes more problems than it is worth, and eventually the pendulum swings to where it ought to be in some happy medium where we recognize the technology is useful, it does some things very well, usually takes a lot of hard work to get it there, so it's robust. But if you don't use it correctly, if you use it on data that's not in the training set, for example, or in a kernel that was not in your training set, things can go very badly. And just quickly, because I want to be able to take questions, this is an example of where we are using it in clinical practice. This is an old scanner. We use it for intervention, and you have to take multiple scans in intervention, and the tube couldn't take it, especially if it was a big patient, so the images looked terrible. Our department chair saw what Andrew had put together and said, please put this on our system. So we do get the really cruddy low-dose image that doesn't make the tube stop, but we also get this denoised image, and I know if I'm having biopsy needles put in my abdomen or chest, I want the bottom image. So there's a close-up of it. So in summary, it has a lot of potential. It is here, it will be more here, it will get smarter and do some of the tasks humans now, but it may be the future, but we still have to proceed with care and a good understanding of what it can and what it cannot do. So acknowledge my colleagues, and again, thank the organizers for having me here.
Thank you very much again for this amazing talk, and also with this black and white of the future. And the question that we receive is very, very fitting with your slides, because the question is, intelligent systems have caused a lot of issues recently, including the 737 MAX crashes. How do you, or do we, ensure that these intelligent systems are being designed in such a way that they are robust and safe? So can you say a little bit more about that? Thank you.
The way to accept and test or commission one of these systems, the way forward is difficult. We are working with the NIH and we're working with the US Food and Drug Administration to try to figure that out, because you can show it images similar to the training data and you'll get great results. But patients have devices, they've had kidney transplants. If you don't try it with that data, you don't know what will happen. And worse yet, those are static. Those weights, when the vendor installs it at your institution, are fixed. They're never going to change. Others are learning systems, so that as the radiologist makes a diagnosis, they mark what it is, that information goes into the training system. And so a month after it's installed, you put the same image in that you started with, you might get a different answer. And that same system went to the hospital across town, and they've trained it differently because their doc, contours things differently, and now they get a different result. And the FDA has not decided how even to begin to approach that.
Thank you very much. We already got a second question, and probably will be the last one because we are close to the end of this time. What role can a clinical medical physicist play in commissioning? Sorry?
No, it's okay. It's 2 questions.
Two more, sorry, it's true. But
Okay,
we will ask
a
the
quick
two.
answer.
In commissioning new artificial intelligence tools, for instance, reconstruction, for clinical use. And I will tell you the second one, so you think about both, you answer both. Are you working with CT vendors to realize this technique to easy access in the market?
Okay, so some of them are in the marketplace. They're working their way there. They're not the complete reconstruction jump because that still is, has a lot of scary things. They're mostly this denoising, even if they call it something different. And the role of the medical physicist, we have a position paper that we've submitted to radiology, and we believe we have the technical training, we have the clinical insight and relationship with both the vendors and the physicians, so we definitely have a role. But exactly how to do it, what phantom you put in is completely unknown because no phantom looks like the training data set. So APM is a bunch of task groups. Any of my colleagues here that want to participate with that, APM is very open to international collaborations.
Okay. Well, thank you very much once more for this great talk.